Oh, where was I? Oh, wait, never mind.
You are
It was
reading the
me.
explanation.
That is the explanation. Yeah. O for organized plan and N for no spouse and S for sickness or sad persons. Borderline, we already know it wasn't borderline. Okay, never mind.
Okay, next.
That's it.
A 70 a 76-year-old a 76-year-old woman who is receiving home hospice care because of end-stage metastatic lung cancer diagnosed 1 month ago and is examined at home at the request of her family because of a 3-hour history of labored breathing despite receiving 100% oxygen at 5 liters per minute via face mask. Pulse is 92 per minute, respiration 18 per minute, blood pressure 105 by 62 millimeter of mercury. Pulse oximetry on oxygen via face mask show oxygen saturation 85%. The the patient appears cachectic and is mild distress showing increased work of breathing with prominent sternocleidomastoid muscle with intermittent agonal respiration. Which of the following is the most appropriate next step in the management? Okay,
So it is A. Give morphine. Help her feel better. That's the point of hospice. Never mind. Administer morphine. Elderly woman on hospice for lung cancer who's having shortness of breath and hypoxemia. Because she's in hospice, we shall prioritize comfort, and common practice in patients with shortness of breath is use of ibuprofen because it can decrease respiratory drive and the perception of shortness of breath, so it makes patients feel more comfortable. Key idea: one could argue that the use of ibuprofen in this patient may be hastening their death. The benefit of improving their comfort outweigh the risk of having them live slightly longer, but with more pain and discomfort. Just because a patient is in hospital does not mean that we do nothing and offer them the intervention. It's just that interventions are geared toward improving comfort rather than treating or curing the disease. Next.
okay. A 42-year-old woman comes to the physician because of 1 month history of moderate constant abdominal pain. She was evaluated in the emergency department 6 weeks ago for renal calculi. Was told that her serum calcium concentration was increased. She has level hypertension treated with hydrochlorothiazide, and in April, two brothers have hypothyroidism, and one sister has adrenal tumor. The patient's temperature is 37 degrees Celsius, pulse 80 per minute, respiration 12 per minute, blood pressure 182 by 98. Fundoscopy examination show heavy nicking. There is mild diffuse tenderness to palpation. The remainder of the examination show no abnormal serum calcium is 13.2, urine metanephrine is 4000. The patient is most likely at risk of which of the following? Is it D? I think that it is men, isn't it? Are you there? Hello, are you there?
Okay, I can hear you.
Okay,
Sorry, I couldn't hear you, but it cut down while you were talking.
okay. I think that it's D, isn't it? It is men 2A, probably.
2A is parapanpit. Parapanpit. 2B, I'm sorry. One is parapanpit. 2A is
Parathyroid, thyroid, pheochromocytoma.
parapan. Okay, so it's 2A. Parathyroid and that, yes. Okay, let's see. Is the wait, with family members with both primary hyperparathyroidism and adrenal tumor, we get sphericomasatoma. We have two out of the men 2A triad. The third is medullary thyroid cancer. Okay. Oh, let me see if this one says something different. Young woman, strong family history of hyperparathyroidism, adrenal tumor who presents with severe refractory hypertension and increased urine metanephrine, pheochromocytoma, and significant hypercalcemia complicated by abdominal pain and kidney stones, which is most consistent with men to a increased risk of medullary thyroid cancer. Oh, here it is. Men one is parapampit, sorry, parathyroid adenoma, pancreatic cancer, and pituitary tumor. 2B is parathyroid cancer, parathyroid adenoma, pheochromocytoma, and medullary thyroid cancer. And 2B is pheochromocytoma, medullary thyroid cancer, and mucosal neuromas. Remember that parathyroid adenoma is in men 1 and men 2A, whereas pheochromocytoma is in men 2A and 2B because PA is like higher than PH. Okay, got it.
Okay, next. A 26-year-old woman with CVID, common variable immunodeficiency, comes to the office because of 2-month history of night sweat. She also has a 10 kg weight loss during the past 3 months despite no change in the appetite. She has a 15-year history of she has a 15-year history of recurrent sinusitis and otitis media. Her only medication is IV IG. She is 163 centimeter, 5 feet 4 inch tall, weight is 54 kg, BMI is 21 kg per meter square. Vital signs are within normal limit. Examination shows cervical and epitrochlear. Examination shows cervical and epitrochlear lymphadenopathy. Which of the following is the most appropriate next step? Okay,
Ready?
yes,
So
lymph node biopsy.
it is lymph node biopsy. People with CV at an increased risk for lymphoma. B. Symptoms like fever, weight loss, and night sweats combined with lymphadenopathy are highly concerning. Okay, this one. Young woman, CV, and chronic history of recurrent infection who presents with B symptoms like weight loss and night sweat, continuous lymphadenopathy concerning with lymphoma, which should be worked up with lymph node biopsy. Patients with CV are increased risk for lymphoma through multiple mechanisms. Yeah, their marginal zone lymphomas can also often be seen in the chronic inflammation, like Sjogren that leads to parotid inflammation, lymphoma, like in chronic autoimmune gastritis that leads to stomach inflammation and mouth lymphoma. Epitrochial lymphadenopathy, lymph nodes in the upper arm often makes me think of syphilis infection, but the presentation not consistent in this case. That's what I thought. Okay.
Next, a 9-month-old boy is brought to the office. 9-month-old boy is brought to the office by his mother because of a 6-hour history of persistent fuzziness and decreased appetite. 2 weeks ago, he was diagnosed with upper respiratory tract infection. The symptoms so, the symptoms since has resolved. He lives with his parents and a pet lizard. His diet consists of cow milk based formula, baby food, and some solid foods. He has no history of serious illness, take no medication, receive no medication. Immunizations are up to date. Today he is inconsolable. He is 50% alone. Length and weight. Examination show multiple flaccid bulla. Examination show multiple flaccid bulla on erythematous base of the buttock. Uh, the mother says she has no knowledge of these findings. Which of the following is the most appropriate next step? What is the diagnosis? Multiple flaccid bulla on erythematous base on her buttocks. Uh, upper respiratory. Okay, let's see.
What is this? This one. 85 is E,
Skeletal
which
survey.
is skeletal survey. I think the description here is a little odd, but a helpful reader suggested cigarette burns, which I think is probably correct. Alternatives could be blistering burn secondary to intentional hot water submission, or really serious spanking, potentially with a wet, well causing object. Either way, not an accidental expected pattern. Whenever the story doesn't make sense or there are any concerned physical exam findings, it's critical to work up for non accidental trauma. Okay, let's see if the other one said something different. Infant with recent illness brought to the office due to 6 hour and inconsolable crying, found to have a rash consistent with second degree burns on the buttocks, red and painful blisters. A mother who's denying knowledge of what happened, which should prompt concern of child abuse. Situation to consider child abuse like bruises, fractures at various stages of healing, injury, story not compatible with development. 8-month-old was running, fell down, and broke his arm. Retinal hemorrhage, well demarcated burn showing classic pattern. See below. Child with signs of abuse should receive skeletal survey. Look for current and past fracture. CT scan of the head. Look for subdural hematoma due to shaken baby. And fundoscopic exam to look for retinal hemorrhage. Quite specific for shaken baby. Pet leaves are risk for non-typhoid salmonella will give a febrile GI illness, so it's not that. And then Saccharomyces cerevisiae antibody is for Crohn's disease, chronic history of abdominal okay. Granulomatous disease nitrogen 2, increased risk of catalase positive, often present with recurrent staph infection, so it's not that. And this is the baby with the patterns, weird patterns. Okay. So,
Next,
mhm.
a 62-year-old woman is admitted to the hospital because of 8-hour history of right severe 8-hour history of severe right upper abdominal pain, nausea, fever that began after she ate fried fish and potatoes. During the past 3 years, she has had 12 episodes of similar pain after meals, but it has not lasted as long. or been as severe as this episode. She she has hypertension, hyperlipidemia, alcohol use disorder. Her medications are amlodipine, benzapril, simvastatin. She drinks one 12-ounce beer daily. She is 5 feet 4 inch tall, weight 86 kg, BMI 33 kg, temperature is 101.3 degree Fahrenheit, pulse is 120 per minute, respiration 28 per minute, blood pressure 100 by 68 millimeter mercury, pulse oximetry on room air shows oxygen saturation 98%. On abdominal examination, there is diffuse tenderness to pulsation, rebound and guarding pulse sounds are decreased. Which of the following is most serum ML? It is pancreatitis, isn't it?
It's pancreatitis. Sure, I guess. But is it pancreatitis because they
Pancreatitis usually we do ultrasound or CT scan, isn't it? Ultrasound is common.
if it's the head, then you do ultrasound. If it's the body, I mean the tail, you do CT scans.
They haven't
Um,
specified this thing.
but here there is the head because the ALT and AST is high, so it's some kind of a stone. So do we
Okay.
do ultrasound first? Yes, we do ultrasound first. Mm, is E? Wait, mine the right thing is E. Yeah, it's ultrasound. Mhm. Now where is the thing?
Okay.
Wait, give me a second. I cannot find the.
Answers.
It's gone. where are the? Where are they? Did I close it?
They went for roaming around.
Oh my God. Anyway, it's just me read this one. Ultra middle-aged obese woman with history of recurrent self-resolving episode of right upper bottom pain after meals, biliary
Hello.
fever, near hypertension, bradycardia, signs of peritonitis, lab consistent with pancreatitis, biliary and liver disease. Amylase lipase are high and low calcium, elevated AST, leukocytosis, cholecystitis, and acute cholangitis, who should be worked up further with right upper quadrant ultrasound to look for biliary disease. Idea: if a patient comes in with obvious signs of pancreatitis, elevated amylase, like abdominal pain radiating to the back, and they don't use alcohol, the next best step is right upper quadrant ultrasound to look for gallstones. If gallstones present, then patient should have cholecystectomy within a few days. And if absent, then patient needs to be worked up for other causes of pancreatitis like hypercalcemia and hypertriglyceridemia. ERCP is indicated for acute cholangitis and pancreatic cyst mass, but importantly, is not indicated in the setting of gallstone pancreatitis unless patient is suspected of having concomitant acute cholangitis. I thought he had cholangitis because often gallstone pancreatitis is not caused by a stone stuck in the biliary tree, but rather the spasm of the main pancreatic duct where it meets the common bile duct due to irritation from passing a stone from a passing stone. Okay. Hmm.
Next.
What happened with my thing? Did I close it? Let me open it back up. It's a weird
Okay.
thing.
Question 87. A 28-year-old woman gravid to para 1, 39 weeks of gestation with an intrauterine pregnancy and is admitted to the admitted to the hospital for induction of the labor. Her pregnancy has been complicated by the gestational diabetes. Treated with insulin during the third trimester and polyhydramnios. Her first pregnancy ended with spontaneous vaginal delivery of a healthy 3,600 gram newborn at term. Leopold maneuver estimate a fetal weight 4,000 gram. The cervix is 2 centimeter dilated, 80% effaced. Vertex is at -3 station. Ultrasonography shows the fetus. Ultrasonography shows the fetus cephalic presentation. The amniotic fluid is 30. IV administration of oxytocin began 4 hours later. The regular painful contraction occurs 2 minutes for last 60 seconds. The cervix is 4 centimeter dilated. Initially, how many centimeter dilated? Okay, 4 centimeter dilated, 100% effect. Vertex is -2. Artificial rupture of the membrane is performed, and there is copious clear amniotic fluid. Fetal heart racing is 10 minutes. Fetal heart racing 10 minutes later is shown. Which of the following is the most likely explanation for the fetal heart racing findings? Ready?
Yeah, it is B. The prolapse, cord prolapse, I think, umbilical cord prolapse. Uh, Tracing shows a prolonged severe fetal bradycardia. This is bad. Causes include cord prolapse, placental abruption, uterine rupture, and uterine tachysystole. Umbilical cord prolapse is particularly common after like rupture of membranes, like artificial rupture of membranes, where rapid descent of the fetal head compresses the umbilical cord, limiting blood flow as it squeezes inferiorly by the contracting uterus. Vertex station doesn't actually matter as one previously thought, but a non-dilated cervix less than 6 centimeters is a risk factor. Let's see if this one says something different. A young woman with complicated pregnancy, polyhydramnios diabetes, who has artificial rupture of membrane followed by a prolonged deceleration um, in like minutes concerning with umbilical cord prolapse. Umbilical cord prolapse should be suspected if a patient experiences membrane of rupture, spontaneous or artificial, and then shortly after develops abnormal fetal heart racing, with common ones being seen in umbilical cord prolapse being fetal bradycardia, variable decelerations, and prolonged decelerations more than a minute. These factors for umbilical cord prolapse, breech presentation, artificial rupture of membranes, polyarrhythmias, management of umbilical cord prolapse, elevate the fetal head and perform C-section. Not appropriate to replace the cord or to allow the patient to continue the labor. Early deceleration, yeah, that's not none of them. Yeah.
Okay. Can you tell me that one, the whale chop? Variable early deceleration, acceleration, late deceleration.
Yeah.
Va- Variable early deceleration, late deceleration, and acceleration, isn't it?
They, I don't understand how you said it this time. You said it first good the first time.
Whale chop, VEAL, variable deceleration, early deceleration, late deceleration, and polyhydramnios,
What? No, now you're saying some. You said something. Okay, variable deceleration goes with
cord,
chord compression.
cord compression,
Early deceleration goes with head compression. Acceleration, which is normal, goes with oxygen, good
oxygen,
oxygen. Late deceleration was with placental
placental
insufficiency.
insertions,
Mhm.
cord compression, variable deceleration, cord compression, early head, and late is placental insertion. Okay, next.
Mhm.
A 63-year-old man with COPD comes to urgent treatment center because of 4-day history of worsening shortness of breath. She use of albuterol rescue inhaler has provided no improvement in these symptoms. Medical history otherwise remarkable. Unremarkable abdomen sorry where I'm okay. Additional medication formoterol budesonide and tiotropium. The patient smoked 2 packs of cigarette for 45 years, but currently smokes only 3 to 4 cigarettes daily, and says that trying to he's trying hard to quit. He appears anxious. He is 175 centimeter tall, weight is 100 kg, BMI 33 kg per meter square, temperature 37.2, pulse 96 per minute, blood um, respiration 26, blood pressure 126 by 7, 128 by 76, pulse oximetry on room air discloses an oxygen saturation 85%. Mild cyanosis is noted, but there is no clubbing or edema of the extremity. Auscultation of the lungs discloses diffuse expiratory wheezes. Cardiac examination discloses distant but regular heart sound. Results of the ABG uh, analysis: PO2 48, PO2 is low, PCO2 is high, pH is low.
pH is normal.
pH is normal. After albuterol nebulizer treatment is administered, the patient reports feeling somewhat better. Then he is feeling jittery and is starting to have a tremor. In addition to providing smoking cessation counseling, plasma or therapy, which of the following is the most appropriate next step? Should we give oxygen?
Why?
Because PO2 is low, and after using the albuterol, there is like tremor, jitteriness. This may be a side effect of the
Of what?
nebulized albuterol.
Oh, okay. Let's give oxygen.
Which one?
No,
I think that
no.
oxygen should be given.
Okay. Okay, let's check. What is it? F. Yeah, oxygen, right? Yes. How many people with SARS in the 80s have you seen not getting oxygen? Okay, he's asking us a question. Titrated oxygen therapy. Early men with COPD, elderly men COPD and significant past smoking history, worsening dyspnea, hypoxemia, and room air, and increased AA gradient. More consistent with the COPD exacerbation. PaO2 48, I don't know what that means. Normal A gradient 16, A gradient 81. Here the A gradient is 33, so it's more than 16. Oh, they calculated the A gradient, which is 81 minus 48. I don't know how they calculated that. Oh, they did the P big AO2 minus the P little AO2. Did they give you all that on the question? Mm, I do not know. I do not see it, but I guess, yeah. Increased AA gradient concerning for VQ mismatch. Acute COPD exacerbation should be treated with inhaled bronchodilators, beta-2 agonists, and anticholinergic, systemic steroids, and supplemental oxygen, with the goal being between 88 and 92. Oxet, plus or minus oxetamivir if you have influenza, and plus or minus antibiotics if two of the three following: increased dyspnea, increased cough, increased color or color sputum. Goal of oxygen saturation for COPD patient not in the high 90s, because this patient often walk around with baseline CO2 retention such that the respiratory drive is desensitized to CO2 levels and relies primarily on O2. So if you push their O2 level too high, it can lead to decreased respiratory drive. Let's see how they calculate it. Let's say 81 minus 48. Well, here is the 48, the PO2. I don't see the 81. Never
Okay,
mind.
leave it.
I'll start with this one, the 85. It's supposed to be 16. Okay, so this is more than 16. Okay.
Okay, now 81, 89. A 49, a 49-year-old woman returned to the office for follow-up 2 weeks after she has invalid 4 months intermittent diarrhea with associated cramping abdominal pain. It also 2 weeks, sorry, 2 weeks after he was evaluated for 4 months history of intermittent diarrhea associated with cramping abdominal pain, urgency, fecal incontinence. Since the onset of these symptoms, he has had 4 to 5 bowel movements daily. He has had 4 to 5 bowel movements daily that contain blood and mucus. Endoscopy done 1 week ago showed erythematous inflamed mucosa of the rectum and the segment column. There were no abnormalities of the ileum. He also had he also had an episode of uveitis treated with intraocular glucocorticoid 3 weeks ago. He takes no medication. He takes no medication. He is 6 feet 1 inch tall, weight 77 kg, BMI 22 kg per meter square. Vital signs are vital signs are temperature 37.3, pulse 88, permanent respiration 18, permanent blood pressure 120/80. Skin examination shows raised tender nodules that are 2 to 3 centimeter in diameter on the anterior aspect of the both lower extremity. Palpation of the abdomen discloses mild tenderness. Rectal examination discloses no fissure or ulcer. Test of the stool local blood is positive. The patient should be counseled that he is at greatest risk of what? Ready?
Yeah.
Okay.
is ulcerative colitis is a risk of colon cancer. The skin lesions are erythema nodosum. Let's see if this one says something different. Adenocarcinoma of the first colon, middle-aged men, intermittent episodes of diarrhea with blood, with colonoscopy showing rectal and sigmoid colon disease. Ileospering, erythema nodosum, ulcerative colitis. Crohn's disease can lead to patchy disease in any part of the GI tract from mouth to anus, but tends to spread the rectum, whereas UC leads to continuous disease that starts in the rectum and typically also involves the colon but spares the terminal ileum. Patients with IBD more UC more than Crohn's have much higher risk of colon cancer and should begin colon cancer screening 8 to 10 years after diagnosis. Both forms of IBD are associated with skin disease like erythema nodosa and pyoderma gangrenosum, joint disease, inflammatory arthritis, and eye disease, uveitis, and oral ulcers. Crohn's specifically associated with calcium oxalate kidney stones, terminal ileal disease, impaired fat reabsorption, increased intestinal calcium. Uh, Calcium binds to fat in the intestine instead of oxalate, and more free oxalate absorbed from the gut. UC is specifically associated with primary PSC, primary sclerosing cholangitis, that leads to direct hyperbilirubinemia. Things that can cause erythema nodosum, sarcoidosis, IBD, tuberculosis, Behçet disease, and the fungal infections like oxy and all those. Okay,
Sorry.
that's it.
Yes. Okay, next. 90. A 27-year-old man is examined in the ICU one day after he sustained closed head injury, liver laceration, and pelvic fracture in a motor vehicle collision. He is intubated and mechanically ventilated. He is receiving IV midazolam 5% dextrose in the lactate ringer solution. Temperature is 37.8. Pulse 95 per minute, blood pressure 100 by 70 millimeter of mercury, cardiopulmonary examination showed no abnormality, the abdomen is soft. He withdraws appropriately to painful stimuli, hematocrit 28, leukocyte count 13,000, sodium 138, potassium 3.5, chloride 102, bicarbonate 24, blood urea nitrogen 20, glucose is 220, creatinine is 1. Which of the following is the most likely mechanism of this patient's finding? Ready?
Hmm. It is a decreased uptake of glucose by sensitive tissues. Trauma and critical illness can cause acute insulin resistance. That's the another one. Decrease uptake of glucose by insulin sensitive tissues. Key idea: insulin resistance is a fundamental response to injury, stress, and is a well known phenomenon in the post op and post trauma patients.
Okay. So in here the take home is
Insulin resistant in post op and post trauma patients.
okay. A 72-year-old woman is evaluated in the acute rehabilitation rehabilitation facility where she has been receiving physical therapy. When she has been receiving physical therapy since sustaining a stroke 2 weeks ago that resulted in moderate left hemisphere, a swallowing study obtained on admission to the facility showed no abnormality. She has been progressing well with her rehabilitation. She is able to walk with the aid of a walker and assistant and has no speech impairment. Tolerates a regular diet. Medical history is notable for weight control, hypertension, and hyperlipidemia. Medications are lisinopril, simvastatin, daily aspirin, lisinopril, simvastatin, daily aspirin. Temperature is 37 degrees Celsius, pulse 72 per minute regular, respiration 12 per minute, blood pressure 130 by 80. Cardiopulmonary examination show no abnormality, cranial nerve intact, muscle strength in the extremity 4 by 5 in the left and 5 by 5 on the right. Sensation is intact, bilaterally standardized assessment of the cognitive functions show no abnormality. For the past 2 days, the patient has insisted that she is well enough to go home despite not being fully cleared to do so by her physical therapist and physiatrist, who wants her to stay for more a week to and to try to advance from walker to cane. She lives with her daughter, son-in-law, grandson, and has a bedroom on the main floor of the house with no need to use stairs. The daughter's works as a stay-home care. Which of the following is the most appropriate next to in the management? Okay, ready? It's A.
It's a don't be. Never mind. Discharge the patient with a plan for home healthcare and physical therapy. This option meets the needs goals of the patient while also ensuring they receive an appropriate level of care. B seems too harsh, and we should not simply withdraw treatment from the patient. C doesn't account for the autonomy of the patient. Let's see. Inform the patient that that's it. Okay. And then D seems incorrect because based on the vignette, your decision making capacity seems intact. Okay. Next.
Next. Yes. 92. A 46-year-old woman comes to the office for an annual health maintenance examination. She reports 6-week history of fatigue. She attributes to working she attributes to working full time and caring for her 3 children. Her blood pressure has been constantly high and measured at home with her husband's automated cuff with many readings greater than 150 by 90 millimeter mercury. Medical history is unremarkable and routine preventive screening include mammography and pap smear have shown no abnormality. He has only medication multivitamin ibuprofen as needed. She is 165 centimeter, 5 feet 5 inch tall, 72 kg. BMI is 26 kg per meter square. Pulse rate, blood pressure is 152 by 98. Physical examination show trace edema of the ankle. A blood urea nitrogen 12, creatinine zero point 0.9, sodium 141, potassium 3.1, chloride bicarbonate 20. So which of the following is the most likely explanation of this patient's increased blood pressure? Hypokalemia is done by hyperaldosteronism, isn't it? Or
Hmm?
Cushing, sorry.
What did you say? I couldn't hear you.
Hypokalemia can happen due to hyperaldosteronism.
Hmm.
Is it hyperaldosteronism?
But shouldn't sodium be high if it's hyperaldosteronism?
Yes, that's the thing. Then it is ruled out. Oh, it is not OSA because patient's BMI is normal. And in Cushing, there is hypertension. It can cause hypertension. Does Cushing cause hypokalemia? And fibromuscular dysplasia like intractable hypertension, like you cannot control constantly, even if you already
I'm
doing
between hypothyroidism and OSA. OSA, hypothyroidism, I feel like she will have other things in hypothyroidism.
hypothyroidism can cause hypertension.
Hy-
Hypothyroidism can cause hyperkalemia,
Hypothyroidism.
hypokalemia.
Mm, feel like she will have other things. But she's
No,
tired.
it's not OSA. Okay, let's see. I don't think so. Okay,
Then it's probably hypothyroidism. Let's see.
maybe it is not the answer.
Yes.
Okay,
Oh,
let's.
it's hyperaldosteronism. Wait, am I in the right question? Yeah, it's
Yes.
hyperaldosteronism. What is it? Hypertension, hypokalemia, adrenal adenomas are a common cause of primary hyperaldosteronism. I guess sodium shouldn't be high. Okay. Middle-aged women with relative normal history, physical, except for persistent hypertension, hypokalemia, and borderline metabolic alkalosis. Most concerning for hyperaldosteronism. Key idea: increased aldosterone levels, whether due to Conn syndrome or causes of RAS activation, hypovolemia, decreased effective, blah, 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 okay, leads to hypokalemia and metabolic alkalosis because aldosterone increases ENaC channels, increase sodium reabsorption in exchange for potassium and hydrogen secretion in order to maintain electrical neutrality. Cushing syndrome said electrolyte abnormalities with increased central adiposity buffalo hormone. Fibromuscular dysplasia, same electrolyte abnormalities with abnormal Brui, and plus or minus neurologic signs associated with fibromuscular dysplasia like dizziness and syncope. Hypothyroidism, weight gain, bradycardia, cold intolerance, delay relaxation of reflexes, OSA, overweight patient, history of snoring, and excessive tiredness, headache in the morning. So I guess sodium doesn't have to be high, it just have to be hypokalemia and metabolic alkalosis, which is by carb is 23 here, so it's like right.
Bicarb is normal.
It's like normal low to the low side, I guess.
Yes, you can say that.
I guess. I guess sodium doesn't have to be high. I guess.
Yes, we need the potassium has to be the low for hyperaldo to happen. In primary hyperaldo, there may be skin finding, isn't it?
Mm,
Okay, let's go to next question. A 50-year-old woman is brought to the emergency department because of 3-day history of severe painful lesion over the right leg and temperature is 38.7 degrees Celsius. She is 12-year history of type 2 diabetes mellitus. Her only medication is insulin. On arrival, temperature is 102 degrees Fahrenheit. Examination of the right lower extremity shows exquisite tenderness to palpation, edema, and warmth. The extremity appears shiny and diffusely erythematous without sharp margin. The subcutaneous tissue is firm, and there are Notable screen breakdown with bulla containing thick purple fluid. Examination of the left lower extremity showed no abnormality. Which of the following is the most approved literature? Shiny diffuse leaded through the
Ready?
1 second, please.
Okay.
Okay, let's see.
Yeah, so it's necrotizing fasciitis. It looks like a bad cellulitis, but then you add skin breakdown and necrosis, and yeah, I guess that's it. What she's saying. Middle-aged woman with type 2 diabetes presented with fever and lower extremity lesion that is exquisitely tender, large sharp margins, and has bullet with purplish discharge. Necrotizing fasciitis. Signs pointing to necrotizing cellulitis. Pain out of proportion to exam, extreme pain, rapid progression of symptoms, severe systemic features like fever, chills, hypotension, crepitus of free air, bullae, purulent cloudy discharge, violations of purple appearance of lesion, paresthesia, anesthesia of age at age of the lesion. Patient with suspected necrotizing fasciitis should go directly to the OR. Diabetic patient predisposed to necrotizing fasciitis of the perineal agent called Fournier gangrene. Okay. Next.
Okay. A 37 a 37-year-old woman comes to the office for a routine health maintenance examination. For the past 6 years, she has worked in a paper mill factory that was liquid chlorine to bleach the paper. He has the patient is concerned about her exposure to toxic substance. Vital signs are within normal limit. Examination show no abnormality. Which of the following is the most appropriate recommendation to approach the patient? Okay.
So it's my lord. So it is D. The key to dealing with occupational exposure is safe practices. That means anything producing a particle or fume needs a respirator. You can fix the damage. You cannot fix the damage that's already done. It isn't. What is it? Using a respirator at work. Inhalation of chlorine gas can lead to lung injury over time. And when trying to approach the problem, try to implement primary disease prevention whenever possible because it's better to prevent disease than to treat that disease. Primary disease prevention, prevent disease before it occurs, like vaccination, wearing a respirator. Second, disease prevention, screen for disease and manage asymptomatic disease like monthly pulmonary function tests. Tertiary disease prevention, treat the disease like steroid therapy. Next.
Yes. A 57-year-old man is brought to the alcohol. 57-year-old man is with alcohol use disorder comes to the emergency department because of 3-day history of worsening abdominal pain and distension. Medical history: alcoholic cirrhosis, hypertension, hyperlipidemia, laparoscopic cholecystectomy 10 years ago. The patient had several physical hospital admission for similar episodes of abdominal pain and distension. The patient takes no medication but has been prescribed medications since medication for hypertension for the past. He recently participated in the he recently participated in an alcohol rehabilitation program, but began drinking alcohol again 1 week ago. During the past days, he has drunk 1 liter of vodka daily. Pulse is 100 per minute, respiration 16 per minute, blood pressure 165 by 85, pulse oximeter in room air show oxygen saturation 100%. The patient appears drowsy. The patient appears jaundiced. Cardiopulmonary examination discloses no abnormality. The reducible mechanical umbilical hernia and diffuse tenderness without guarding. There is no tenderness to percussion. In addition to large volume of paracentesis and furosemide therapy, in addition to the following formulation of the following is the most appropriate. Oh, span. Okay, it's spironolactone. Ready? Ready?
One moment, please. Okay, yes. Is the spironolactone. Spironolactone helps reduce ascites production and is the diuretic of choice for the initial treatment of portal hypertensive ascites. Okay. Yes. Middle-aged men with history of alcoholic cirrhosis who still drinking and present with signs of decompensated cirrhosis like big abdomen, positive fluid weight, who should therefore be treated with spironolactone because it is the diuretic of choice for cirrhotic ascites. Unfortunately, cannot easily reason through this question, just an important fact to commit to memory that has been shown time and time again. Will also argue to begin propranolol both to target hypertension and to decrease risk of variceal hemorrhage. Yeah. And in this case, they are mainly focused on managing the ascites in the setting of cirrhosis. That's why I was confused. Because propranolol could also treat this, but okay. Okay.
Okay, next. 96. 96. A 48-year-old man is admitted to the hospital 2 hours after the onset of severe abdominal pain, nausea, and vomiting. The pain radiates to the back but improves when he bends forward. He has no history of serious illness, takes no medication. He does not smoke cigarettes, drinks 12 oz beers weekly. He appears restless. He is 173 centimeter tall, weight is 90 kg, BMI is 30 kg per meter square. Temperature is 38, pulse is 110 per minute, respiration is 20 per minute. Blood pressure is 102 by 60 millimeter of mercury. On pulmonary examination, decreased breath sounds are heard at the lung bases. There is dullness to percussion. Abdominal examination shows distension and severe tenderness to palpation of the epigastrium and left upper quadrant. Hemoglobin is 13.5. Serum urea nitrogen is 30. glucose 120 milligram per deciliter, glucose 120 milligram per deciliter, creatinine 1.2, cholesterol 300 tg, 1500 milligram per deciliter, total bilirubin 1.1, amylase 300. Administration of IV fluid and analgesic is begun. The patient's abdominal pain, nausea, vomiting decrease. Which of the following is the most appropriate next step? Oh, it's hypertriglyceridemia causing pancreatitis, isn't it?
Mm, yeah, probably. Mhm.
Is it, is it gem fibrosing, isn't it?
Yes. I don't know. I don't remember what's the difference
Yes,
between
yes,
SEC.
it's gem fibrosing.
Ready?
Fenofibrate and gem fibrosing. These are the drug of
Okay.
choice for hypertriglyceridemia. I don't know
Okay.
why my brain is nowadays working so slow. I need
So
to take something.
is this gemfibrozil? Severe hypertriglyceridemia is an important risk factor for cause for pancreatitis. Fibrates remain the drug of choice for severe hypertriglyceridemia. Let me see something else. Middle-aged men without significant alcohol history presented with abdominal pain radiated to the back, elevated amylase, and tags in the 1000 more consistent with pancreatitis due to hypertriglyceridemia. Key idea, most of the time statins are the best. Lipid lowering agent with one key exception being the setting of hypertriglyceridemia. Associated pancreatitis should be treated with a fibrate because they lead to the most profound drop in tag levels. Diagnostic criteria for acute pancreatitis, two of the three, back pain radiate, back pain radiating, oh, I think it's front pain radiated to the back, amylase or RAP N or lipase more than 3, that's high. Imagine finding consistent with pancreatitis. Two most common cause of pancreatitis is alcohol and gallstones. With a mnemonic to remember most causes being I get smashed. I for idiopathic, G for gallstones, E for ethanol, T for trauma to the abdomen, S for scorpion sting, oh, M for mumps, A for autoimmune, S for steroids, H for hypercalcemia, hypertriglyceridemia, and D for drugs like sulfur and HIV.
Okay. Next, a 57-year-old man is admitted to the hospital 30 minutes after he was found wandering in the street. Finger stick blood glucose concentration obtained by the paramedics prior to the transport was 68 milligram per deciliter. The patient, the, this patient's medical history is unknown. Temperature is 35, pulse 80 per minute, respiration 16 per minute, blood pressure 106 by 70 millimeter of mercury. The patient appears disheveled and is not oriented to the person, place, or time. Physical examination shows mild conjunctival icterus. Cardiopulmonary examination discloses no abnormal. Abdominal examination discloses small fluid wave. There is pulmonary 1 plus pitting edema of the lower extremity. Gait is broad and ataxic. The patient is unable to cooperate with ocular or neurologic examination. ECG shows regular sinus rhythm, no acute abnormalities. Results of the toxicology screening are pending. The most appropriate initial step in the management to administer which of the following? Is it thiamine? Isn't it thiamine? Varnic?
Ready?
Yes.
Is B, a cirrhotic wanderer, completely disoriented, while potentially just intoxicated or suffering from hepatic encephalopathy? The question is again probably getting to Wernicke. Treatment is thiamine is harmless, and that's why lots of drunks get the banana bag. I forgot what was the banana. Vitamin B1. Middle-aged men with signs of cirrhosis, like the icterus and fluid weight and palmar edema, brought to the hospital with altered mental status and ataxia concerning with alcohol intoxications versus Wernicke. Patients using substance who is brought to the ED with altered mental status should almost always receive naloxone, thiamine, and glucose. And importantly, as discussed in previous cases, they should receive thiamine before glucose because glucose can lead to shift of water soluble vitamin into the cell that can push a patient into Wernicke encephalopathy. Wernicke encephalopathy classically leads to confusion, ataxia, and thermoplegia. Super key on the MBME when you see alcoholic, you should translate that to malnutrition. Wernicke folate deficiency scurvy. Next.
Okay. 3 days after an operation for uterine cancer, a hospitalized 67-year-old woman developed edema of the right lower extremity, and Doppler ultrasonography shows the review of the patient's record indicates that no degree prophylaxis was initiated perioperatively. Best which of the following is the best approach to prevent a similar adverse event in the future?
Ready?
Yes,
Is B, the
develop
standardized one.
develop an institutional policy with a standardized order for DVD prophylaxis.
Algorithmic standard approaches that reduce variability are the hallmark of high quality care. Not everyone can receive heparin, but everyone needs to have a DVT prophylaxis plan so they don't fall through the cracks. Okay, let me see. The answer to this question is often standardization of human error prone tasks and on intervention that improves communication between healthcare members. The answer to this question is rarely educational policies. So that excludes A. Where is A? Where is it? A. Conduct nursing in service regarding DVT prophylaxis. Okay. Early ambulation and anticoagulation in the early postoperative period. While they are good policy for most patients, may not be appropriate for a patient and therefore should not be applied universally. Okay.
Next, a clinical trial is performed. A clinical trial is performed to assess the efficacy of aspirin in decreasing the risk of in decreasing the risk for myocardial infarction. 20,000 male physicians, sorry, 22,000 male physicians with no history of coronary artery disease are randomly assigned to receive aspirin or a placebo after following the sub following the subjects for 5 years. Results showed that incidence of myocardial infarction is in the aspirin group and 2.2% in the placebo group. The reduction in incidence is statistically significant. Which of the following is the most appropriate interpretation of this result? ARR is like aspirin group minus MI group, isn't it? Oh, placebo group. Sorry, placebo group and the drug. One or some, no, needed. Number needed to treat 1 divided by ARR, isn't it?
Mm-hmm.
And relative risk reduction 1 minus relative risk,
Mm-hmm.
and
Or
or risk exposed minus risk unexposed. Okay, it is A,
is
2.2 minus 1.2.
yeah, is A. Yeah, just the risk in the placebo minus the risk in the aspirin group. And the relative risk reduction will be one minus relative risk, which one will be one minus the risk in the aspirin over the risk in the placebo. Number needed to treat will be 100, I guess. That's what they're saying. Okay. Okay.
Next, yes. An 18-year-old man is being prepared to undergo left temporal craniotomy for meningioma. General anesthesia has administered. The surgeons review the most recent MRI findings, which are hanging on a view box in the operating room, and prepares the clip the hair from the patient's right scalp. The circulating nurse is concerned because the signed operative consent for from the indicator of left temporal craniotomy. Which of the following is the most appropriate course of action for the circulating nurse? Left.
Ready?
Wait. Okay.
So I see. Stop wrong side surgery is a big no-no. Everyone on the team should feel empowered to stop a surgery or procedure if something in the procedural checklist is amiss. So it is ask the surgeon to continue the operation only after the discrepancy is resolved. Definitely, we want to verify the operation start before beginning, narrowing it down so you can eliminate B, C, and E. Yes. With B being incorrect because it's not the circulating nurse's responsibility to do the MRI. E is incorrect because it would be inappropriate to call the patient's parent to confirm because they may not be in the waiting room. Two, the patient is an adult, so his medical records are confidential. It will reflect poorly on the surgical team that they don't know which side is correct. Okay.
Okay. A 52-year-old a 52-year-old man is brought to the emergency department because of 2-day history of severe progressive shortness of breath associated with exacerbation of his chronic cough. He has 6-week history of pneumonia, which has responded slowly to treatment prior to the onset of the current symptoms. He had minimally productive cough with mild shortness of breath. After walking 1 or 2 blocks, he also has low-grade fever for 6 days. He has no history of serious illness. Current medications are erythromycin and all over the cough suppressant. He has smoked 1 pack of cigarettes daily for 20 years. On arrival, he appears ill. He is diaphoretic and in severe respiratory distress. He is diaphoretic and in severe respiratory distress. His temperature is 38.1. Pulse is 110 per minute. Respiration are 36 per minute. And shallow blood pressure is 70 by 50. Pulse oximetry on room air oxygen show oxygen saturation 83%. Mm, examination show perioral cyanosis. There is there is no general there is no jugular venous distension. Diffuse crackles and wheezes are heard throughout the lungs. Heart sounds are normal while a blood sample is taken. The patient's blood pressure decreases. He stops breathing. He is intubated, mechanical ventilated. Lab hematocrit 42, lymphocyte 16,000, segmented neutrophil 85%, and lymphocyte 15%, platelet count 22 lakh, ABGPA 7.35, PCO2 42, PO2 55, chest exit diffuse, alveolar infiltrate, no cardio. Following IV administration, blood pressure 118 by 80. Which of the following is the most appropriate next step in the management? Okay,
Okay, so the answer is E. Pip is like Cobwell, Cobweb, Cobwell. Okay, not really, but where am I? When gas exchange is insufficient with increased FiO2, PEEP will help open alveoli and increase the functional area available for ventilation. Does not make sense. Okay, it's application of PEEP, positive and expiratory pressure. Middle-aged men with smoking history and likely COPD, even baseline history presenting respiratory distress with significant hypoxemia despite mechanical ventilation, with X-ray findings of diffuse bilateral alveolar infiltrate, most concerning with ARDS. Oh. Patients with ARDS are typically managed with ARDS ventilation strategy, which basically advocates for high PEEP with the low tidal volumes. When a patient is mechanically ventilated, oxygenation is based upon inspired oxygen and PEEP. So in this patient who continues to have hypoxemia despite receiving 100% oxygen, the only course of action is to change the current ventilation setting by increasing the PEEP.
okay. 14-year-old girl is brought to the 14-year-old boy is brought to the emergency department by his parents 30 minutes after the sudden onset of confusion. Uh, Confusion, sweating, pallor. He has aneurysms treated with imipramine. Our parents refilled this prescription imipramine 3 days ago and noted today that the bottle is empty on arrival. The patient is awake and but confused. Temperature normal, pulse rate, respiration 8 per minute, blood pressure 100 by 60. Examination should dilate pupil and flush skin. In addition to ensuring airway, establishing IV access between the following is the initial management.
Mm. Anti-ham histamine. Alpha one aspirin. Cardiac monitor. Cardiac monitor.
Ready?
Yes. One moment. It is a this is a cardiac
Cardiac
monitor. TC overdoses and potentially fatal due to drug cardiac effects. The most dangerous is that fast sodium channel blockage can lengthen the QRS and result in fatal ventricular arrhythmia. Let me go back to this one. Observe it. Wait, am I in the right one? No, yes, this one did not. Never mind. We don't have an answer for that yet.
monitor. Okay, next. A 65-year-old man with hypertension, with mild hypertension, comes to the Veterans Administration outpatient clinic because he is concerned about having an AAA, abdominal aortic aneurysm. He says he feels well. His medications are metformin and lisinopril. His older brother, his older brother, was seemingly in good health, recently underwent, was seemingly in good health, uh, recently underwent emergency repair of the ruptured abdominal aortic aneurysm that has not been diagnosed previously. The patient is retired from the military, 15 years, small one pursued for 20 years. Uh, Blood pressure 140 by 85. No organomegaly palpation. The aortic pulsation is estimated 3 centimeter inward. There is mid-epigastric bruise heard. Which of the following most appropriate?
Ready?
Yes. Okay.
We see test of choice for triple A is screening is ultrasound, cheap and radiation free. Let's see if this one has. Okay, yeah. Doppler ultrasound of the abdomen. Here, the USPSD recommendation are that males 65 to 75 years of age with any smoking history should receive a one-time duplex ultrasound to screen for abdominal triple A. Important to contrast with lung cancer screening, which should occur in patients of either sex, but only if they are between 55 to 80 years of age and have a smoking history at least 35 years, and they have smoked within the and they have must be smoked between the past 15 years.
Ready? A 57-year-old man comes to the physician because of 1 month history of fatigue and moderate low back pain. He also has mildly decreased appetite, resulting in 1.8 kg weight loss during this period. Has a week he has a 1 week history of headache. He has had no fever, sweating. He has had no fever, sweating, or chills. He has hypertension well controlled with triamterene and hydrochloride. Has had other medication include 81 milligram of aspirin, ibuprofen, and a daily multivitamin. He appears tired. Examination shows slightly pale conjunctiva. A grade 2 by 6 systolic murmur is heard. A grade 2 by 6 systolic murmur is heard at the lower left sternal border. The remainder of the examination showed no abnormality. Test of the stool for occult blood is negative. Hematocrit 32%, MCV 102, leukocyte 9200, segmented neutrophil 66%, bands 3%, lymphocyte 31%, platelet count 3,25,000. RDW red cell distribution white is 15.6%, serum calcium 10.8, urea nitrogen 18, glucose 108, creatinine 1.5 milligram per deciliter, albumin 3. X-ray of the lumbosacral spine shows mild osteopenia. Which of the following is the most appropriate next step in the diagnosis? Okay,
Okay, so it's serum protein electrophoresis,
multiple myeloma.
back pain, normocytic anemia, fatigue, hypercalcemia, concern for hematopoietic process, particularly multiple myeloma, serum protein electrophoresis will demonstrate the MSI. See if this one says something. Middle-aged men presenting with fatigue, back pain, anemia, hypercalcemia, mild creatinine elevation, multiple myeloma. You need SPEP, serum protein electrophoresis. Most cases of renal dysfunction lead to hypocalcemia and increased phosphate binding to calcium, vitamin D activates kidney disease. So if you see renal dysfunction, hypercalcemia, you should heavily consider multiple myeloma.
Okay. A 38-year-old woman, Gravida Paravan, comes to the office because she has been unable to conceive for the past year. She and her husband had unprotected sexual intercourse 3 times weekly during this time. They have 6-year-old daughter. During the past year means have occurred at irregular 90 to 120 day interval. Her last menstrual period was 2 months ago. Means previously occurred at regular 30-day interval. She used an oral contraceptives for 4 years after the birth of her daughter but discontinued it 14 months ago. She has no history of serious illness, takes no medication. The patient appears well. She is 5 feet 4 inch tall, weight is 63 kg, BMI 24. Vital signs are within normal. During examination show no abnormal results. Serum studies are shown TSH 3, FSH 100, prolactin 10, beta CG negative. Prolactin FSH is high, isn't it?
Mm-hmm.
The patient's diagnosis puts her at risk of each of the following.
Ready?
1 second, please. Okay, ready?
With D, osteoporosis, the decreasing and irregular periods coupled with high FSH suggests early menopause. Estrogen helps with bone strength. The lack predisposes to osteoporosis. Osteoporosis, 38 woman, normal weight, who was able to conceive the child 6 years ago, who now presents with difficulty conceiving in the setting of irregular menses. Found to have normal prolactin and increased FSH, most concerned of premature ovarian failure, menopause before 40. Premature ovarian failure, decreased lifetime estrogen exposure. Premature ovarian failure leads to low estrogen, increased risk of osteoporosis. We know that menopause, osteoporosis, so it makes sense that early menopause will also lead to osteoporosis. Typical risk factors for premature ovarian failure is history of radiation, family history of Fragile X syndrome. In the setting of oligoamenorrhea, if SH is high, it tells you that hypothalamus and pituitary are functioning, but ovaries cannot be stimulated, like menopause or primary ovarian failure. Whereas if FSH is low, then you know the problem is lies in the pituitary or hypothalamus. Yeah. Next.
A 27-year-old man comes to the physician because of 1 month history of progressive fatigue and episodes of moderate abdominal pain. She has 4 year history of recurrent nosebleeds that have been increased in frequency despite undergoing cauterization of the nasal mucosa 6 months ago. He takes no medication. His sister has anemia associated with recurrent nosebleed and a heavy menstrual period. She also had post PPH that require transfusion. The patient's vital signs are within normal limits. Examination shows pallor, no other abnormalities are noted. Lab shows hemoglobin 7.1, erythrocyte 2.1, leukocyte 13,500, platelet 2,50,000, prothrombin time 12, PTT 45.
Which one is high PPT?
Von Willebrand disease has high PTT. PT is for, I think that it is H. Von Willebrand.
That should be it. Last man from Bastille. Okay. So it is a bomb Willy brand. Increased bleeding with normal labs or just isolated increased PTT. It's always a good picture for von Willy brand. This is the most common bleeding disorder. Yes, PTT is slightly elevated, which can happen, but that's also why they probably gave you a boy and girl siblings to help you not pick hemophilia. Makes sense. Young man who has sister with bleeding problems, who himself has recurrent nosebleed refractory to treatment, anemia, and prolonged PTT, most consistent with von Willebrand. Von Willebrand disease primarily a qualitative platelet disorder, nosebleeds, petechiae purpura with normal platelet count and increased bleeding time. But can also lead to a mildly increased PTT because von Willebrand is a protector for factor 8, which is part of intrinsic coagulation pathway. Ophelia A is linked, so will be rare to have a sister. It's X-linked, so no sister will have the disease. Hemorrhagic telangiectasia leads to not big telangiectasia in most concerning AV fistulas with higher foot heart failure. Next.
Yes. Isn't it endoscopic finding
Um, okay.
or colonoscopic finding?
Don't
Colonoscopic.
for that.
Okay, let's see. A previously healthy 57-year Old man comes to the physician because of 2 month history of mild lower abdominal pain and generalized fatigue. Our only medication is a daily multivitamin. Her father received the diagnosis of prostate cancer at the age of 70. The patient is 160 centimeter, 5 feet 3 inch tall, weight is 58 kg, BMI 23 kg, temperature 37, pulse 98, respiration 14 per minute, blood pressure 110 by 84, abdominal examination shows no abnormality. Test of the stool for occult blood is positive, hemoglobin is 9, hematocrit is 27, colonoscopy examination has shown biopsy specimen of the mass is the ascending colon, shows a moderately differentiated adenovirus in which of the following. Okay, ready?
One moment.
Ascending colon.
Mm, okay, let's see. So it's E, colon cancer, surgical disease. Okay,
Right
let me see.
hemicolectomy.
Right hemicolectomy, middle-aged woman with 2 month history of fatigue, abdominal pain found to have anemia and moderate differentiated adenocarcinoma in the ascending colon. Most consistent with right-sided colon cancer, surgical resection is the treatment of choice for virtually all stages of colon cancer. Surgi- okay, regardless of site. Okay.
Ready? Next.
Yeah.
A 37-year-old woman comes to the office for a follow-up examination 3 weeks after testing confirmed a mass in her left breast to be benign. She says that despite the test results, she has an anxiety, insomnia, and preoccupation with cancer since noticing the lump. 2 weeks ago, she had a 20-minute episode of markedly intense anxiety characterized by heart palpitation and the fear that she was dying. She says she has always been tense, nervous person and is uncomfortable in social situations. She says she frequently worries and is or fearful of the future and apprehensive of dying. She has no other history of panic disorder, traumatic event, serious illness, and takes no medications. She does not drink alcohol or illicit drug. Physical examination shows 2 centimeter mass in the left breast. On mental status examination, she is cooperative but worried. Her thought process or linear content focuses on possible negative eventualities. Which of the following is the most approved? Next.
Ready?
Yes.
So it's B, GAD, part of DMS-5 criteria for GAD, general anxiety disorder, excessive anxiety and worry, apprehensive, occurring more days than not for at least 6 months, about a number of events or activities such as work or school performance. Okay, let me see if they say something else here. Young woman with chronic history of anxiety that has been exacerbated by recent cancer scare and continues to stress her out despite reassuring testing, most consistent with GAD. Key idea. GAD diagnosing patient with chronic symptoms more than 6 months, worries about a bunch of life issues. Patient may have some component of illness, anxiety disorder, preoccupation with having a serious illness. Often, despite medical evaluation and reassurance, and social anxiety disorder, the relative fear of embarrassment in social situations, but that wouldn't explain her chronic history of um, anxiety about other issues unrelated to breast cancer.
Next, 55 55-year-old man comes to the emergency department because of 6 hour history of diffuse abdominal pain, subjective of fever. His most recent bowel movements 4 hours ago was loose but not bloody. He reports no chills or urinary symptoms. Medical history is remarkable for GERD and his an alcoholic cirrhosis. Medications are summarized spironolactone, lactulose, and pantoprazole. The patient appears uncomfortable, temperature 100, pulse 88 per minute, respiration 14 per minute, blood pressure 104 by 66. Physical examination shows conjunctival icterus and abdominal distension. Bowel sounds are normal. There is moderate diffuse abdominal tenderness and with mild guarding, but no rebound tenderness. Results of the lab have shown ALT 70, ST 85, ALP 66, total bilirubin 3.5, creatinine 0.6, hematocrit 39, leukocyte count 11,300, platelet count low 66,000, PT high, PTT normal, PT is high, PTT normal. Abdominal biosynthesis is done, analysis acetic fluid shows segmented neutrophil. Isn't it SBP?
Maybe.
Yes, maybe A.
Above the diaphragm, below the diaphragm. Mm, okay. So it's a ascites, sorry, hypotaxim. Ascites with a neutrophil count higher than 250 is consistent with spontaneous bacterial peritonitis. Treatment of choice is a third-gen cephalosporin as hypotaxim or ceftriaxone. See if this says something. Middle-aged men, alcoholic cirrhosis who presents with diffuse abdominal pain and fever, with abdominal paracentesis showing neutrophils more than 250, consistent with spontaneous bacterial peritonitis. Main treatment spontaneous bacterial peritonitis, third generation cephalosporin, whereas some cirrhosis patients can receive fluoroquinolones for prophylaxis. Cytic fluid more than 250, diagnosis of SBP. Patients with cirrhosis often don't mount as robust autoimmune response in the setting of infection, so temperature won't be that high or above. Some temperature of 100 or above should make you concerned. Anytime a patient with cirrhosis presents with other mental status, diffuse abdominal pain, high temperature, or index of suspicion of LVP should be high, and patient should receive a paracentesis.
Next, a 45-year-old man is brought to the emergency department because of moderate chest pain. After a generalized tonic-clonic seizure 30 minutes ago, he has seizure disorder for which he has taken carbamazepine and phenylbutyrate for the past 20 years. X-ray of the chest shows generalized osteopenia and severe fracture. Which of the following is the most likely nutritional?
Ready?
Mm, I think so. It is vitamin D. Why folic acid causing osteopenia?
Mm, yeah, I guess it doesn't make. I know carbamazepine. No, no, it's not carbamazepine that causes folic acid.
Phenytoin.
Phenytoin. You're right. You're right. You're right. It's probably vitamin D. Carbamazepine. Yeah. Okay, let's check. This is
Am I wrong?
is vitamin D. No, you're right. Wait, no, no, no. Wait, I forgot what question we're in. Is 110. 110 is E. You're right. It's
Okay.
vitamin D. AED induced bone disease. I don't know what AED means. Disease is a problem with long term therapy.
Anti-epileptic
Carbamazepine,
drug.
anti-epileptic. Okay. Carbamazepine and phenobarbital induce CYP450 and can cause vitamin D deficiency. Oh, God. Vitamin D deficiency of the Malasia rickets causes weak bones and plus signs of excess bone deposition in response to insufficient mineralization, like frontal bossing, rachitis rotary, waist widening. PID and many antiepileptic drugs, including phenobarbital and carbamazepine, lead to induction of cytochrome P450, which leads to increased metabolism of vitamin D and can lead to vitamin D deficiency, seen in up to 50% of patients taking long-term antiepileptic drugs. Mm. Carbamazepine also associated with folate deficiency, but that will not affect bone health and will instead lead to melobarastic anemia. Okay, so carbamazepine also close. Okay.
Next.
Mhm.
A 32
Oh, wrong one.
a 32-year-old man comes to the office because of 2 day
Oh,
history.
can we take a quick break?
Yes,
Okay, have
yes,
my
obviously.
yes, sorry. Okay, have my breakfast.
A 14-year-old girl is brought to the physician by her mother for a well child examination.
Oh no,
Vitamin.
we are in 111.
Oh, sorry. A 32-year-old man comes to the office because of 2 day history of redness in the red eye. Sorry, redness in the right eye. He has not had sensitivity to the light or sensation of a foreign body in the eye. He has no history of serious illness, takes no medication. Examination of the right eye shows erythema, clear discharge. Examination of the left eye shows no abnormality. The physician prescribed ketorolac ophthalmic solution. Which of the following is the most appropriate way for the physician to write the prescription? Ready?
Yeah,
Okay.
it is a write it out abbreviation and like assumptions. Ketorolac 0.5% solution, one drop in the right eye 4 times daily. Although we use abbreviation to expedite not writing and other tasks related to documentation, the MDME likes to emphasize that using clear language that is generally interpretable is best for avoiding mistakes or issues with communication. Next.
A 14-year-old a 14-year-old girl is brought to the physician by her mother for a well child examination. Vital signs are within normal limit. On breast examination, the areola are 3 cm in diameter and form a secondary mound bilaterally. Cardiopulmonary and abdominal examination shows no abnormality. Pelvic examination shows dark curly coarse hair spreads sparsely the pubic hair but not over the thigh, which is only most appropriate. Okay, it's normal, isn't it?
Answer is D, normal, normal. When it comes to development questions, always make sure before you pick something other than normal if offered. Tanner stages are available. 14-year-old girl Tanner stage 4 breast and pubic hair development reflecting normal development. Um, Primary amenorrhea diagnosed in girls who have not had secondary sexual changes like breast development by 13, who have not had menarche by 15. Normal female pubertal development often involves breast changes beginning at 8 to 12 years old, followed by 1 to 2 years later by growth spurts, then followed 6 months later by first menstrual period. It's boob, pubes, and whatever. And here it's showing. Okay, next.
A healthy 19-year-old woman comes to the clinic requesting advice regarding contraception. Mens occur at regular interval. Mens occur at regular 28-day interval with a heavy flow. She is sexually active and has had three lifetime male partners. She has smoked one pack of cigarettes daily for 2 years. She lives in a college dormitory and says that she often does not sleep in her town room and has trouble remembering to take medications regularly. Her only medication is daily multivitamin. She is 163 centimeter, 5 foot 4 inch tall, weight 58 kg, BMI 22, vital signs are within normal limit. Physical examination shown. Which of the following recommendation contraceptives? Okay.
So is the implantable birth control is much more effective than methods that require active effort. Let me see if they put something else here. Subdermal contraceptive implant, that's the answer. Often placed in the upper arm and can be effective for 3 to 5 years, although vaginal ring must remove and replace every month. And oral contraceptive are highly effective form of they require more effort than the subdermal implant. Condoms, vaginal diaphragm, and other forms of Viagra are not as effective as hormonal contraception and therefore are basically never the correct answer in MBMA. This patient will likely not be a good candidate for PPID because she has heavy flow, and the PPID can lead to even heavier flow. Okay. Next.
A 56-year-old man with adenocarcinoma of the lung comes to the physician because of one history of shortness of breath with exertion. The cancer was diagnosed. The cancer was diagnosed 6 months ago. He completed a course of chemotherapy 2 months ago. He has hypertension treated with hydrochlorothiazide, temperature 37, respiration 18, blood pressure 114/64, pulse oximeter on room air, oxygen saturation 94%. There is dullness to perfusion of the right lung base. There is dullness to perfusion of the right lung base and decreased breath sounds are heard. Chest extension, thoracentesis show which of the following.
Ready?
Yes.
Let's go back. Malignant pleural effusions. F. Um, Cancer is full of protein. Okay, let's guess. The answer is increased total protein concentration. Middle-aged men with lung cancer who recently completed initial course of chemo presents with progressive dyspnea on exertion found to have dullness to perfusion, a percussion and decreased breath sound in the right lung base with chest area consistent with right pleural effusion, which is secondary to malignancy. So it's exudative effusion. Lies criteria. If at least one of the following conditions are true, then the effusion is exudative. Pleural fluid protein more than serum fluid protein, so more than 0.5. Pleural fluid LDH more than serum fluid LDH, or pleural fluid LDH more than two-thirds upper limit of serum of normal serum LDH, which is often like 200. Exudative effusion are due to increased vascular permeability, often in the setting of inflammation like cancer, infection, or autoimmune disease. And you can remember that um, they have fluids and extra substances like protein cells, LDH, whatever. Transudative effusion are often due to increased cytostatic pressure at volume overload due to CHF, CKD, or decreased oncotic pressure like nephrotic syndrome and malnutrition. PMI is a world of purulent fluid collection secondary to infection. You'll see decreased glucose concentration and increased neutrophil count. Okay, next.
A previously healthy 17-year-old boy comes to the emergency department because of 3-day history of because of 3-day history of moderate right lower quadrant pain, fever, loss of appetite. She has not had abnormal vaginal discharge. 4 months ago, she was treated with oral antibiotic for cystitis. She currently takes no medication and suffer at regular 28 days interval. Her last menstrual period was 10 days ago. She has been sexually active with two male partners during the past 6 months. Use condom inconsistently. Temperature is 101, pulse 105, respiration 14, blood pressure 127/82. Abdominal examination shows tenderness to palpation of the lower quadrant with rebound in the right lower quadrant. There is no distinction. Bowel sounds are decreased. Pelvic examination shows blood tinged discharge from the cervical fossa and cervical motion to release. There is 5 centimeter mass in the right adnexal region. Which of the following is the most likely diagnosis? Her pregnancy test is positive.
Oh, did they give the pregnancy test here?
No,
So why are you saying this positive?
as
Confused.
because you have chosen ectopic pregnancy. That's why.
Oh, I thought it was.
Ectopic pregnancy test. Without pregnancy test, you can't say that it is ectopic. At
Oh,
least
so you don't know.
urine should be present.
Okay, so if in the question they don't give the pregnancy test, that cannot be a topic.
Usually, no. I think that as it is, there is fever, so abscess can one of the differential.
Okay, then if it's not a topic, then it's to Bavarian. It's one of the two. The other ones
Why
don't
it
make
is
sense.
not torsion?
What is not what?
Torsion.
She's been having it for 3 days, and why would torsion have bleeding?
Why torsion has?
Bleeding,
Okay.
and she's had it for 3 days. That's torsion. It will be like immediate. It's either to Bavarian or ectopic pregnancy. But since you said ectopic pregnancy, I guess it's to Bavarian. The other ones just don't make sense. Ready?
Yes, yes.
Okay. So it's E. Wait, what was E again?
Tube ovarian.
Ovarian abscess. Inconsistent condoms, code phrase for STD. A young woman with high risk sexual practices, okay, I guess, multiple partner, whatever, who presents with right lower quadrant pain, fever, blood tinge discharge from the cervical or the cervical motion test. Then there's more consistent with PID complicated by ovarian abscess. Only diagnosis that can explain the cervical discharge and the fever. Okay, okay. Young woman with lower quadrant abdominal pain, you should think differential will be appendicitis, fever, right-sided only, ectopic pregnancy, protracted pregnancy test potential hemodynamic instability, ovarian torsion, reduced Doppler flow, especially in patients with known history of ovarian teratoma due to unbalanced network, PID, cervical motion tenderness, high risk sexual practices. So pregnancy potential. Okay. Of the above diagnosis, the only one that's classically related to fever and to fever, appendicitis, and PID. Okay. Although cervical motion tenderness is most associated with PID, it can also be seen in ectopic pregnancy and endometriosis. So don't immediately jump to PID in the setting of cervical motion tenderness. Okay. Ectopic pregnancy excluded given patient's menstrual history, often seen in a patient who has not had a period on the order of weeks to months. When was her last period? Meses occurred about the last period was 10 days ago. It's weeks. Okay, I guess
Mm,
it's not enough weeks. Okay, but pregnancy, I guess the fever wouldn't, they wouldn't have fever. Okay,
yes.
okay. Next.
A 15-year-old girl is brought to the office because she has never had menstrual period. She has no history of serious illness, received no medication. Growth and development are appropriate for age. Breast development began at the age of 10 years. She has never been sexually active. She is at 90 percentile for height, 75 percentile for weight, 69 percentile for BMI. Sexual maturity rating is 4 for breast development. Pelvic examination shows normal appearing vagina. The cervix and the uterus cannot be palpated. Her serum testosterone is 340, serum concentration of the LH, FSH, and TSH, 17 hydroxyprogesterone, and prolactin within the reference range. Serum beta HCG is negative. Pelvic ultrasound show no uterus. Her karyotype is 46XY. Which of the following is the most appropriate? Next. Okay.
Okay, the answer is B, gonadectomy. Externally normally developed female with 46XY male karyotype. Elevated testosterone in no internal sex organ is consistent with complete androgen sensitivity syndrome. While somewhat controversial, particularly with regards to timing, gonadectomy is recommended to remove the undescending gonad to prevent cancer. In this case, she's already gone to puberty. If the gonadectomy is performed earlier in childhood, then puberty will need to be induced with hormone replacement therapy. Let's see if it shows anything different. 50-year-old girl, primary amenorrhea with the XY karyotype, elevated testosterone, absent uterus, androgen insensitivity syndrome. First step, remove the testicle due to high risk of malignancy. Yeah. Key idea, primary amenorrhea diagnosed in girls who have not had secondary sexual changes, like breast development by 13, or who have not had menarche by 15. Patients with androgen and sensitivity syndrome have normal breast development due to aromatization of androgens. To estrogen, breast tissue development but will have absent axillary pubic hair because growth of hair in those areas are driven by testosterone in both men and women. First step in primary amenorrhea workup determine if uterus is present with physical exam and imaging because if it's absent then the patient either has Mullerian agenesis, XX normal breast pubic capillary hair development, or androgen insensitivity syndrome, XY absent pubic and axillary hair with normal breast development. Second step is in primary amenorrhea workup. If patient with primary amenorrhea has uterus, then check for FSH level because low FSH tells you pituitary hypothalamus is dysfunctional. Normal FSH tells you they have a functional defect like imperforated hymen. And an elevated FSH tells you the ovaries are dysfunctional and cannot be stimulated, like Turner syndrome. Okay, next.
Okay. 50-year-old returns to the office for a follow-up examination. During the past 2 months, he has had increased risk of blood pressure readings during several checks at the office and at home. He says he has felt well. He has major depressive disorder. Medications are fluoxetine and allopurinol. His maternal grandmother had congestive heart failure. The patient's older brother has hypertension. The patient has smoked one half of cigarettes for 32 years. He is 180 centimeter, weight is 95 kg, BMI 29 kg, pulse 70 per minute, blood pressure 152 by 90. Which of the following is the medication is contraindicated in this patient? Why? He has
Hmm,
gout.
it has gout. Oh, so no. Right. Ah,
Okay, ready?
let's see. It is C, thiazide, and others Symporter and loop diuretics can result in diuretic-induced hyperuricemia and cause or worsen the gout. Um, the answer is hydroperoxide. Hydroperoxide can lead to hyperuricemia and therefore should not be used in patients with gout. Main side effects of thiazide can be remembered with pneumonic hyperglucemia, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Mm, okay, next.
A 23-year-old a 23-year-old woman A 23-year-old woman is brought to the emergency department by her friends 30 minutes after the sudden onset nausea and facial flushing and chest pressure while eating at Thai restaurant. He does he does not make any known allergies to food or medication. He has asthma during childhood and but has not required treatment for 5 days. On arrival, she is diaphoretic, appears anxious. Temperature is 37.1, pulse 92 per minute. Respiration 20 per minute, blood pressure 126 by 68 millimeter of mercury, oxygen saturation 99%. Examination of the neck show erythema, no mass or nodules are palpated. Cardiopulmonary examination shows no abnormality. Which of the following is the most likely diagnosis?
Ready?
Yes.
Is D, the reaction to the food. This is MSG symptom complex. I don't know what this stands for. Sometimes historically and pager called Chinese restaurants syndrome. While MSG gets a bad rep, real MSG sensitivity is rare. Let's read on reaction to food additive. Young woman who has eaten at a Asian restaurant and developed nausea, facial flushing, chest pressure, most concerning for an adverse reaction to monosodium glutamate. Oh, that's what it said. Okay. Constellation of symptoms previously termed Chinese restaurant syndrome due to Chinese restaurant using a lot of monosodium glutamate. But name has now been changed to MSG symptom complex. Panic attack wouldn't last 30 minutes and often not associated with rash. It's not systemic mastocytosis, rare disease due to accumulation of mast cells. Episode similar to allergic reaction with urticaria, itching, GI symptoms. Other random reaction associated with food is scombroid poisoning, which leads to headache and lightheadedness after eating spoiled fish. Okay.
Okay. A 45-year-old woman returns to the office to discuss the results of a prenatal aspiration biopsy. Zero point 0.5 centimeter right breast mass obtained 1 week ago. She is unaccompanied. Medical history is unremarkable. She takes no medication. Her mother and maternal aunt were diagnosed with breast cancer at the age of 45 to 52. Physical examination discloses no palpable axillary nodes. The biopsy specimens show malignancy. The patient is counseled that she has an excellent chance of cure with lumpectomy and radiation therapy. He adamantly, he adamantly refuses this treatment plan and states that she will try natural therapy, include mega vitamins and herbal remedies instead. After exploring the reason behind the patient's decision, which of the following is the most appropriate response? Okay, ready?
Yeah. Answer is C. Um, ask her to return in 2 weeks to discuss. Don't be a dick, but you don't have to entirely give up either. She may come around after her crazy simmers or don't know what it means. Ask the patient if she'll be willing to return to the office in 2 weeks to discuss treatment options again. Receiving bad news can be disorienting, shocking experience, and therefore it will be important to speak with the patient in a few days, weeks later after she has had time to fully process the news and think about her care. Answer F will destroy the patient physician relationship. Answer B will lead to poor outcome for the patient because cancer patients shouldn't go without care for 6 months. And answer D will be inappropriate because you shouldn't immediately refer a patient to another physician because you disagree with their choices. Okay.
A 47-year-old woman comes to the office. 2 month history of progressive weakness and numbness in her legs. She has 3 year history of type 2 diabetes, one is treated with metformin. She has worked as a stock person in the storeroom for 12 years. She often moves and lifts heavy objects, sometimes crawls into the tight spaces. On neurological examination, muscle strength is 5 by 5. A is the hip extensor thigh abductor hamstring gastrocnemius muscle on the right and intact on the left. Muscle strength is intact in iliopsoas thigh adductor quadriceps and tibialis anterior muscle bilateral. Deep tendon reflex is 1 plus in the right ankle and 2 plus in the left ankle. Sensation of the light touch is mildly decreased over the lateral and the inferior aspects of the right foot. Sensation uh, otherwise is intact. Which of the following is most likely diagnosis? Isn't it S1?
Okay, let me check. It's F, sciatica. Wait, S1, radiculopathy. Let me see. Middle-aged women with risk factors for radiculopathy like heavy lifting, who presents with weak knee flexion, hamstring knee flexion, and calves plantar flexion, decreased Achilles reflex, and decreased sensation of the lateral inferior foot, which matches with S1 radiculopathy. The monitor to remember lower extremity myotomes is lower extremity myotomes L3, raise your knee, hip flexion. Okay, L4, kick the door, knee extension, flexion extension. Okay. L5, lift your big guy, dorsiflexion, and big toe extension. S1, jump for front plantar flexion. So L3, L4, L5, S1. Okay. Way to remember lower extremity dermatomes. L3 covers the medial leg at the level of the groin, and then the nerve roots will spiral around the leg thigh from the medial surface. L3 to the anterior surface, L4. Oof. To the lateral surface, L5, and lastly to the posterior surface, S1. So L3, L4, L5, lateral, and S1. Okay. The money for main lower extremity reflexes, L2, L3, kick the door is for the patella reflex, so at the knee. S1, S2 for the Achilles tendon. Okay, we are done.